Bronchiectasis is a permanent structural failure of the respiratory system, characterized by the irreversible widening of the main bronchi. This widened airway structure prevents the lungs from naturally clearing mucus through the typical upward escalator motion. Because the fluid remains stagnant in these dilated pockets, it creates a persistent reservoir for chronic bacterial colonization. These specific British Thoracic Society guidelines govern the management of adults aged 16 and older, and they strictly exclude patients suffering from cystic fibrosis. Clinical investigation begins when a patient presents with a persistent, mucus-producing cough and ongoing breathlessness. Non-CF bronchiectasis represents an irreversible mechanical defect, locking the patient into a perpetual cycle of airway infections that requires lifelong, proactive management. Because these symptoms overlap with many other respiratory conditions, clinicians must follow a tiered diagnostic imaging approach. A high-resolution CT scan is an absolute requirement, providing clarity to see the physical widening of the bronchi. In contrast, a standard chest X-ray serves as a baseline tool to rule out other acute diagnoses, lacking the resolution to confirm bronchiectasis. Beyond imaging, clinicians utilize secondary laboratory testing, specifically blood and sputum samples, to identify the catalyst of the airway damage. These tests screen for a range of underlying causes, including past pneumonia, tuberculosis, immune deficiencies, or pre-existing conditions like asthma and COPD. A precise diagnosis requires dual confirmation, high-resolution visual proof of structural widening, and lab results that isolate the biological driver of the disease. The BTS 5-step algorithm functions as a rigid, quantitative protocol for escalating care. Clinicians escalate based purely on the annual frequency of a patient's exacerbations. Step 1 applies to every diagnosed patient, centering on a personalized self-management plan. To compensate for the loss of mechanical lung function, a respiratory physiotherapist must teach the patient physical airway clearance techniques. These rhythmic breathing exercises use physical pressure to force trapped fluids out of the widened anatomical pockets in the bronchi. At this baseline level, bacterial infections are treated reactively with standard courses of antibiotics as they occur. Clinicians also use Step 1 to treat any underlying illnesses and administer annual influenza vaccinations to reduce overall respiratory stress. Step 1 relies on manual mechanical assistance and reactive medications to manage the permanent loss of structural lung function. The algorithm shifts when a patient crosses a critical threshold, with exacerbations ticking past 2 per year. In Step 2, clinicians introduce therapies designed to alter the physical properties of the mucus when physical therapy alone is insufficient. Patients may use nebulizers to inhale a mist of sterile water or saline, which thins the excess secretions for easier clearance. Alternatively, mucoactive tablets can be prescribed to chemically reduce the total volume of mucus the lungs produce. If the patient still averages more than 2 exacerbations, Step 3 mandates the introduction of long-term antibiotic strategies. If the specific bacterial strain is identified, clinicians use targeted long-term antibiotics, delivered either orally or through inhalation, to suppress that pathogen. When the infection type is unknown, the protocol recommends long-term macrolides. Unlike acute treatments, long-term macrolide use inhibits bacterial division. This slows growth and reduces infection rates over several years. Crossing the threshold of 2 exacerbations per year forces a shift toward chemically modifying the mucus and maintaining persistent bacterial suppression. Step 4 triggers when a patient fails to drop below the 2 exacerbation threshold despite Step 3's interventions. This requires stacking therapies, combining a long-term macrolide with an inhaled antibiotic. The final threshold is reached when exacerbations surpass 4 per year, activating Step 5. At Step 5, the clinician moves from localized inhaled or oral therapies to systemic intravenous antibiotics. This aggressive systemic treatment is typically administered on a schedule of every 2 to 3 months. Steps 4 and 5 represent the maximum pharmacological force in the BTS protocol, reserved for cases where prior interventions failed to control colonization. Because the anatomical widening of the bronchi is irreversible, the risk of bacterial infection remains a permanent factor in the patient's life. Stable patients must still attend an annual checkup to ensure their respiratory physiotherapy remains effective. Continuous bacterial monitoring is essential, allowing clinicians to detect and respond to new colonizations, even when the patient appears stable. Worsening symptoms or new infections require a swift alteration of the treatment plan and a move to an earlier follow-up appointment. The BTS 5-step plan focuses on a disciplined escalation of pharmacological force to preserve lung function and maintain the patient's long-term quality of life.